Here we go. Hey, everybody. Well, here we are. We're back on Thursday night. And this is the best thing because it's not just the three of us, but it's the four of us because we have Rob's cat, Sai, which I think is the most exciting. And look at her. She actually has beautiful colors. Usually we just see her being kind of wild. And
she's still pretty wild.
Wild. She's still wild. And she is beautifully colored.
She's still wild.
And still wild. That is awesome. Oh my gosh. All right. How are you guys? Have you guys had an okay week?
Yes. Did you get a ton of snow? Rob, we got a fair amount, but not like we were forecast tons of snow and everything was canceled, but yet nothing really happened. So
yeah, not too much in our area. I don't know, 2 days ago I think was the ice, like we got more ice and stuff than any snow, but most of it, I mean, we had one good sunny day yesterday, kind of, even though it was cold, it was still, the sun was out, melted a lot of it. So
no, we're way into school vacation week, so
Woo, that's nice. Right. That's a phenomenon of New York and Massachusetts. Apparently, not a thing here in the Mid-Atlantic. People do not get that week off. Yeah. So, all right. Well, look. Let's. Hi, guys. Oh, look at our Thursday night crew made it over here to the Facebook, which is great. It was the gram was being glitchy for me tonight. But let's get right to it. So let's sort of hit the topics here at the top of the half hour, so that we can tell everybody what we're going to be talking about. So I'm dying to talk about viral load mostly because I like to say the term viral load. There's just something.
It's such a viral load.
I know, right? Yeah. And
right.
That actually has some relevant. There's a lot of relevancy about it. So I think we're going to talk about that. Let's talk about hit the new guidelines for quarantine if you are a fully vaccinated person, because I think that's a new thing from the CDC. We need to talk about MISC because there's been a fair amount about that, and I'm anxious to hear your thoughts on that, Dr. Murray. And then we're going to see how the wind blows us after that one. So
might chat about a little humor in medicine. Yeah.
Right. Exactly. All the good stuff. So, okay. So let's get to it. Rob, when we talk about viral load, I think the easiest way to think about that, right, is that it refers to the amount of virus in your system.
Absolutely. Yep.
Am I right on that? Yeah. How?
Yeah. And I mean, it can be also related to any pathogen too. So, I mean, it does say viral load, but like if you think about it in terms of a bacteria also.
Right. Okay. So how do people, I mean, I just want to know the science here. We always start with the basic science. How do you calculate and figure out a viral load? So here's what happens. When I'm seeing patients, I swab the inside of the nasal mucosa and get a specimen that I then send to the lab. Take it from there. What happens and how do we calculate what that viral load is?
So from there, you're really just looking at the genetic material of whether something is present or not present. So that's going to tell you, do you have COVID or do you have the flu or something else? That's what most of those tests are doing. I know you guys have talked about that in the past, like the antigen test looking for a protein versus the PCR test actually looking for DNA or RNA.
Yeah.
So that will be the actual test and how that runs, whether you get a positive or negative result. But actually determining the viral load, I think it's not really something that can be done on a test for like a person. More so that would be something that's like more calculated in a lab setting. If you're like purposely going to induce a system, see how does increasing viral load relate to maybe an increasing severity of symptoms or whether somebody actually gets sick or not. Because every day we're constantly faced with a lot of different pathogens in our body. We're destroying bacteria or maybe viruses and we don't even know we have them. So that's probably a low amount of viral load, not enough to get us sick.
Right.
Our immune system can take care of that. That's why we have our immune system ready. It's just unfortunate if sometimes things get a bit out of control, kind of like a snowballing effect, especially with the viruses and bacteria that can replicate so fast that if you do have a higher amount of viral load, usually that relates to your immune system can't get to it in time. It has time to, start an infection, start replicating, and that's when you get those, more sick symptoms. And I think that that's also why sometimes we see some people getting more sick or less sick, even though they're still having a positive COVID result. But one thing that I think is really important to discuss related to viral load is that, vaccines, considering viral load, are still very important. But here, rather than actually giving us a virus, we're giving instructions to make a protein or the protein itself. We've talked about the different mechanisms in the past, and those have been carefully titrated or calculated to give us, the strongest immune response possible, even stronger than if you were to get infected. Because when you are infected with COVID-19, you're not only trying to defend your own body, you're also trying to make antibodies. But here, the only thing we're trying to do is make the antibodies. So kind of all resources have been shuffled into that, and for our immune system, and we don't need to worry about trying to kill the pathogen or the virus that's in our body.
So I'm curious about this because there have been some preprints and some papers that I have read that that specifically look at the viral load that is in that patients carry, vaccinated patients carry, and there is some data that's emerging, right, that is indicating that for vaccinated persons, the viral load in the nose, in their nasopharynx, is sufficiently low that it would be unlikely that they are transmitting the virus. So that's the thing that we're all waiting for, right? That's what we know, that the vaccine really works. Have you seen that, Dr. Murray? So I'm wondering, how are they calculating? How do they know that viral load is low? What's the assay? What's the lab assay that they're doing to figure that out? That's what I don't know. That's basic science. That's lab science.
Oh my God. Are you going to make us talk about Western blots and all that? No.
Right?
And there's so many things. So, and the viral load also is playing a role in people when they're not vaccinated, when they're ill and they're going through their incubation period and that kind of stuff too, right? So it's not as though you get exposed and boom, you're just a virus machine. It takes a little bit of time. And so as you're going through that process, the body is, as Rob was saying, is taking a two-prong attack of trying to fight it, but then also trying to realize what it is and build antibodies too. So, and then build some immunity for it should you face it again in the future. But as you're kind of going through that whole process, it's potentially a catch-up game where the germ is going, replicating, and you might have a big viral load, and then that's when you're getting symptomatic and you're sick and you're feeling bad. And at the same time, your immune system's coming in and trying to overpower and stop that load from increasing, stop that virus. So, we're going through that phase when we're sick as well, versus the symptoms we're feeling post-vaccination is just the immune response reacting to what it sees as foreign in your body without infecting you.
Right. Yes. It is.
We've heard this concept before. This is something that's discussed with HIV. There's other viruses out there that we look at viral load. And for HIV, there's other things, of course, too, that can be monitored to check for treatment. We just don't necessarily have, there's the COVID long haulers, but COVID is an acute self-limited disease for the most part versus HIV, which is a very different process, but that viral load concept still exists.
Right.
Yeah. And I think the PCR comment is definitely true, but it's also not like you're going to tell someone they have 100 versus 105 or 200. It's more like a range, right? You have X thousand number versus 10,000, or whatever. It's not so precise. Also, just to make clear for other individuals not in the science field too. It's more
the orders of magnitude are huge.
Yeah, magnitude.
Factors.
Yeah. And I think that is, and that's probably the extent of my understanding of it. But I think that, and I get what it means. I just mean in terms of sort of how it's calculated and how they do that. But I think that the important thing to know is that is what is being looked at when we look at sort of effectiveness or likelihood of transmissibility, which is, I think, the one of the really big questions that remains that needs to be answered. So viral load, that's a term to be familiar with. It's something to know about. And we can certainly talk more about it.
Don't expect like, oh, you're sick. Hey, let's check my viral load to see how sick I'm going to be. That doesn't work.
No.
That's not a thing. So, it's not going to be a predictor of how long you're going to be sick, or am I going to really have symptoms, or any of those kinds of things. It's an academic value.
Right. Very good point.
Meaning it's a researchy thing. It's not something that most likely we are going to put into practice with this germ. Other germs, yes, but this germ, no.
Exactly. Right. Not a clinically relevant. Yep, exactly. All right, so let's talk a little bit about, before we sort of move on beyond that, some doctors saying people may only need one shot of the Pfizer in the New England Journal. Anybody? I didn't see that today.
I did not see that either, but I'm still standing strong on my, it was studied one way, let's use it the way it was studied.
I think for right now.
How I'm feeling on that.
Yeah, I mean, I think that was, I know that conversation happened a lot related to vaccine to access issues when there were, which, that still exists, but when there weren't enough to go around, the thought was, hey, look, we know that after one vaccination, one dose of these mRNA shots that we have, reasonably good 54% effectiveness or something like that. And boy, that's as good as what we get with the flu shot. So should we just lean forward and lean into that? Looks like Dr. Gary Gerlacher saw it. And so Dr. Gerlacher, put something in the comments if that was something that was different from this conversation. But I think that Dr. Murray's point is well taken. That this is, we need to use it as it was studied and as it was rolled out. And I think most of the scientists have now agreed after that whole conversation. So I think that certainly makes sense. Okay, thoughts on a booster shot moving forward? Anybody know? I think we don't know is the answer to that.
We just don't know. Yeah. We just don't know.
We don't know, but right now, I mean, everyone, the people they have studied in the clinical trials still are producing that spike protein antibody. And what is it? We're moving 8-9 months since then. So I think that it's reasonable that it's going to last at least
as long as we keep the mutations down.
Right.
Absolutely.
Down.
Yeah.
Exactly.
Spread, not letting it mutate.
Yeah.
Right. Totally right. And so I'll take a look at that from the New England Journal. I was reducing elbows and taking out stitches and doing that all up until about an hour ago. So I did not see that today, but I will take a look in the New England Journal and comment. Okay, let's pivot a little bit.
But I think that this also could lead into like the other, just briefly, how we were going to maybe talk about designing the other mRNAs for mutations. I know we briefly brought that up.
Yes.
And, this could kind of follow into that. Like if there is going to be a third shot or, just an additional shot to take into account some of the mutations, which I know Moderna is already starting to work, and they've been working on it for like a month now. They already have the technology ready. So when they designed this technology, they needed to figure out like what was the best way to deliver it. That was with the LNP or the fat molecule. So they know the right composition of that. That doesn't need to be altered. The only thing they really need to change is the instructions. So just making some adjustments to the actual code, which is going to just change what amino acid it brings in at a specific position. I still think those need to be tested. I don't know, in a clinical trial, I guess, because it is new. Anytime you change the sequence, I think that is considered a new biologic. Yeah. But the actual pipeline should be even faster. So that's the cool thing about already having the technology ready to go. Yeah. Swipe it out and go.
And actually on the Moderna website, they kind of talk about that, and they're trying to make it relatable. So they talk about it being an operating system and how you can just kind of do that. And I've seen so many anti-vaxxers now take it of like, haha, see, It's a computer system. It's plug and chug. They're not thinking about it. It's like, no, it's just the way they're making it relatable because people understand that terminology and they're just making it relatable. So this is not some computer programming that's being put in your body. It's the same four ingredients. It's the same simple stuff. It's just now the hard work was done and there's just a little bit of things that can be changed out to make it more efficient, more effective moving forward if the need arises. So it's not really an operating system for a computer.
Right. We all know, I think
that way.
audience cue when Rob can't keep a straight face anymore. You know that things are really scientifically implausible. Just completely like you can't even handle it. It's so, right. Oh my God. It's exactly right. And in the comments, Dr. B making a absolutely appropriate comment that they may end up being the safest vaccines ever with being dissected as they are, which I think is really very, very, very true, very true comment. And I love that. Okay, great. So let's pivot a little bit and talk about, let's do MISC after this, but recent change in guidelines about needing to quarantine after exposure for a vaccinated person. I think it's just important to know about those. Do you want to share that, comment on that, Dr. Murray?
Sure. So it's just kind of funny because it's like, yay, you don't have to quarantine if you fit these 12 criteria. So it's really it's kind of a nothing burger because, you've had to have both of your shots. You have to be, 2 weeks out from your second shot. You still have to be asymptomatic. You have to be within 3 months of your second shot as well. And I think that's the one that people keep forgetting to mention. It's not a free-for-all forever. It's you have to still be 3 months from your last shot for this to count. Now, once we get more people who are 3 months past their last shot, will these things be adjusted again? Probably. Who knows which way it's going to go because the variants could go up, the variants could go down. We don't know. But I'm fearful that they're going to go up, but fingers crossed they're going to go down. So, yes, this is nice. But again, if you develop symptoms, you don't just get to say, oh, it's just a cold. If you develop symptoms, you still have to go in quarantine and probably want to get tested. But the big point here is once you're 3 months beyond your last vaccine, those rules are currently, as of today, are not applying to you anymore.
So you've got like 5 minutes where you don't have to actually quarantine if you get exposed. I'm kidding.
Right. And so the first group are about 6 weeks out from their second vaccine now. So I think tomorrow I'm 6 weeks from my second. And so that the people who were vaccinated right at the beginning. So we'll see. We'll see.
Right. But I do think that that's going to be shifting. And the reason that I bring this up as sort of important info for anybody who's watching is that you really do want to keep a little bit of an eye on how this stuff pivots. Because it might seem like it's confusing. It's hard to know. I hear people tell me all the time, it is so hard for me to know what is current, what to believe, what is real. But so I think that the more that you kind of get in the paradigm that things are always changing, I think it becomes a lot easier to adjust when and are very sort of conversant on where things are right now. So that's where they are right now. So important one to know about for sure. Okay, so MISC, let's talk through that a little bit. That was, and it's been so fun having Rob teach us all these things that we finally got to share a little bit of our knowledge and expertise with Rob.
I know, that was great. Right? We were discussing our show, and he's like, wait, what's this thing? I said,
what is that?
We will teach you all about it. It is the fear in parents right now is what it is.
That's right. So
but important to bring up. I mean.
Walk us through that latest stuff, Dr. Murray.
So again, the name gets me, MISC, every time because it makes me think of the Mickey Mouse song, MISCKEYMOUSE, which is not really how it goes, but that's what I always think of. So it's multi-system, it's inflammatory response. So basically the hypothesis is that this is a pediatric specific. The average age is around 9, but the range is anywhere from 1 to 20 years of age. At some point after having a COVID-19 infection or coronavirus infection, COVID-19 disease, it could be concurrent with active infection or it can be many weeks later. Most are probably weeks later. people are kind of having this overwhelming inflammatory response that kind of looks like this old thing we've seen for a long time called Kawasaki syndrome, but there's a lot of components of it that are different. And so there's this very, very strict diagnostic criteria set, which is really almost very limiting, because my guess is that there's more kind of versions of this that are happening out there, but this criteria is so highly specific that there's a lot of kids out there that are really, really sick with something that we don't know quite what it is. It's very similar, but they're not meeting the technical criteria, so they're not counting. But basically, fevers, low blood pressure, sometimes rash, and sometimes joint pain, all sorts of very unusual lab tests that just usually we don't see those types of results in kids whatsoever. They can certainly have an impact on the function of the heart as well, and these kids are getting really sick. So what we saw is back around the first surge, a couple of weeks after that, this was starting to pop up, and then it went away for a while, and now the numbers are starting to come up again. There's a lot of discussion now that people are seeing, and we don't have a ton of data on it yet, but just kind of the general discussion across the country is it seems to be that right now that the kids who are getting sick with this are getting even sicker than in the past, and they don't know right now, is it related to the variants? There's not a lot of data to support that right now, but that's a theory that's being looked at, but we're trying to figure out why is that. So overall, throughout the country, these numbers are reported every month, and they lag behind a month. So we really, most current we have is basically through December at this point, which showed about a little over 2,000 cases and 30 deaths. So when you look at the deaths from COVID, it's almost around 200 deaths from COVID-19, which for perspective, last year, which was a pretty bad flu year for children, I think we had 188 pediatric fatalities. So COVID-19 infection has unfortunately cost the same amount of lives in children. But if you look at the number of MIS-C diagnoses and the number of deaths, it's a much, much more concerning phenomenon of 2,000 with about 30 deaths versus millions with about 200 deaths when you look at the regular COVID-19 illness itself. So a concerning problem. It's the one thing that seems to be unique to pediatrics here with this germ, where historically most of COVID-19 kids have been able to do very, very well with. And so this is certainly the concerning thing. Some new information coming out on possible therapies for this to help. But what we do know is whether you have COVID-19 or if you have MIS-C, one of the primary concerns is long-term injury to the heart and the heart function. And so that's going to be followed very closely as well. But this was something we were worried about with the numbers going up. And there's some data now starting to come out that unfortunately our concerns were justified, that the numbers looked for a while like they were going up. Again, though, the numbers lag quite a bit behind. So the complete data for January is not yet in.
Yeah. And I think this is a really good question that Julianne has. Do we know if most kids were with MIS-C were originally sick or asymptomatic? And it's a combination.
Right, but the latest data shows the majority were known to previously have it. They don't necessarily. I don't know that how they were all super sick with it, but they were known to have it. It was a very, very, very small percentage did not. Were not aware that they had previously had COVID-19. So, but most knew they had the diagnosis. There was definitely some, but a high number knew that they had had COVID-19 at some point.
Yeah. So I think that the implications for us in practice. And I think for parents at home, if your child had COVID-19, and if you're looking at somewhere in the 3 to 6 week window after that, and they develop symptoms of abdominal pain, of new fever, rash, vomiting, diarrhea, that's a very common presentation, and that they are quite ill. And it's fever that needs to be present for 3 or more days. So it can't, it isn't just, oh my goodness, just one fever out of the blue in the afternoon. That needs to be taken fairly seriously. And we are screening those with lots of different blood tests. And I think the other piece, the racial disparities piece that's being brought up is
very important.
Very important. Yeah.
Yeah. Huge discrepancies here. And it's very interesting, a little unclear why, because it doesn't necessarily match up with the number of pediatric COVID-19 infections. There was not as much of a disparity in the pediatric population with the primary infection. So it's interesting that we're having the greater effect seen in the children of color.
Yeah.
Yeah,
Dr. Rich.
But it could also be due to just the disproportionate amount of individuals who are being infected, and if it's coming home to their families.
True.
That can spread to their children just as much, because we do know
Yep.
that Black and Hispanic Americans are being infected more and
Yes,
are dying
adults
at a
are,
higher
definitely.
rate. So it's something we need to be, considerate about too.
Agreed.
In the adult population, most definitely. Yes. Yeah. And I think so. Another key point for parents is this is not going to be subtle. You don't have to say like, is something wrong? Am I missing it? Your child is going to be very symptomatic and be sick with a bunch of things, with, again, the belly pain, the vomiting, diarrhea, fever. A lot of stuff is going to kind of come up, and they're going to not be acting like their normal self. So it's not a thing where you have to, kind of worry of, oh, maybe they had a little bit of an ache. This is not going to be subtle.
Yeah.
You'll know. You'll know something's wrong.
That's exactly right. And I'm flashing up Dr. Rich Bruckner's comment. Rich has diagnosed a couple of MIS-C kids in the office that I am aware of. Thoughts on cardiac clearance post-COVID, even without MIS-C? I think that's an important thing to bring up as well. So let's hang on to that one for a sec, because we'll bring that up in just a sec. But any specific age is more likely to develop MIS-C?
The tweeners, the greatest numbers were right around 9. So 8 to 10. But again, it encompassed all ages. Yeah, it encompassed all ages, but the greatest numbers were 8, 9, 10.
Yeah, I think so. I think it is, but it is important to note that, just if you've got a 14-year-old or if you've got a 2-year-old, you're not in the clear. And our index of suspicion is quite wide for this. Yeah. Okay. So that's do you think it's inevitable? Not everyone not vaccinated will at some point get COVID, no matter how careful you are.
I don't think so.
I don't think so either. Yeah.
I don't.
Yeah, I think.
I think there's been more severe and more, not that this isn't severe, sorry, that was a bad choice of words, but more contagious diseases like smallpox, for example, that we've been able to eradicate. I was just reading a really great book about it, actually. If I remember, I'll post it in the comments afterwards, just about how the process of vaccination was able to eradicate that, in India and in certain parts of Africa in the mid 50s, 60s, just through vaccination efforts. So I think that we can get there. It's a matter of everyone doing their part and following the guidelines, which we know has been extremely difficult from the start for some reason.
Really tough. I had a lot of noses out today in a medical facility.
Yeah.
So that was tough stuff. Is there a treatment for MIS-C if it's caught on time? Yes, there is.
Yes.
You can.
But let's be clear. I find in medicine a lot of times when people say treatment, they mean cure. So is there supportive care and there's therapies to help? Yes. Is there a turn it off cure? No, there is not. Yeah.
Yep. Absolutely correct. All right, let's get back to Rich's comment. Cardiac clearance after COVID. So for everybody or for return to activities. So I think that's a difference, right? So we know that for sure right now that a child who has had COVID, and especially a child who has been sick, so not even necessarily needing hospitalization, but a child who has had more than several days of fever, absolutely needs to have an evaluation before they return to vigorous physical activity of any kind.
But that's not too complicated. That's a evaluation by a pediatrician and an EKG. It doesn't mean an echocardiogram. It doesn't mean extensive evaluation. It's pretty straightforward. That a regular pediatrician's office can handle just fine.
Yep, exactly right. But I think Rich's question is sort of interesting. What do we need to broaden that cardiac clearance after COVID if somebody doesn't have MIS-C? Is there any reason to broaden that? That's an interesting.
Well, I thought that for anybody who was hospitalized with COVID-19, any child who's hospitalized with COVID-19 or any will require clearance regardless of if they're an athlete or not. That everybody is getting, at least that's what we're doing here locally. I believe everybody who's been so severely ill that they require hospitalization does go through a clearance process.
Even if
it's the milder cases that are kind of falling out of the algorithm. Originally, that when the algorithm, it was everybody And then it's people over 12 and then 12 if you're an athlete or participating in certain sport, so it's kind of evolved. It's a moving target, but for the sickest kids, I think so.
Absolutely. Yeah, absolutely right. And I think that it is, and I think those guidelines are going to continue to change as we know more. So I think that's a fact. So those numbers we are going to need to watch, and we'll need to see. I mean, I'm going to be most curious as we're starting to see, as everybody knows, because it's been all over the news, that there's been a drop in cases, in hospitalizations, and in testing. And so I think that's good news for us. But I think as spring break starts to happen and people start to travel and all of that, I think we're gonna continue to see little spikes and bumps along the way. And so because of that, expect also that we will see the spikes in MISC cases as well. So
my husband's ICU is below normal pre-pandemic census for the first time in months. So.
Oh my gosh. Yeah, good to be on service this week. That's
not well, no, I mean, it's great. No more extra weekends for right now. Not gonna work.
Yeah, for sure. Wow. All right, look, so half an hour in, and let's go through the humor and professionalism in medicine drama, because this is where everybody can weigh in, right? Everybody,
right.
All 48 people
That's
who
right.
are here with us chickens, and get Cy. Where's the cat, Cy? We can get the cat in.
I know.
Right? But so set the stage for us, Dr. Murray, for what this was all
about.
So
for those on the Twitter,
masks.
Okay. Those on the Twitter,
and so,
there's an ophthalmologist who's great. I can't say his name right. Dr. Glockham Flecken is the account name. He's an ophthalmologist. He actually has always been a comedian. Kind of before he became big on social media, he was a comedian too, and would do that in addition to his day job of being an ophthalmologist. And so he's actually great on TikTok, and he's created this following, and he's very, very good, as they say, kind of punching up, never punching down. But all of a sudden lately, and his recent kind of stream of videos have been great, where it's kind of the medical student perspective with each of the specialties. He did a fabulous job with the pediatrician, Rainbows and Unicorns, but they've all been very funny, especially for people who've gone through medical school.
Yeah.
And so, but all of a sudden there's been some comments from people saying, this is ridiculous. You're not being professional. How dare you? This is humiliating to you. And so it's really launched this huge discussion about what is being professional. And he, of course, had his opinions, which I tend to agree with. But what were you going to say?
Yeah, I was going to say that some of the comments that I thought were very interesting were, you should keep your sense of humor out of social media completely.
Where we need it most.
Which I
look at my feed today. We need some humor in there. I got all sorts of stuff going on in there today.
Yeah, which I thought was really interesting. So I'm really curious. People comment make a comment about what you think about that. Is it do you want to see your physician as a human being, kind of who they are outside of their physician identity? And I think that this doesn't apply to just physicians. I think it applies to nurses. It applies to scientists. It applies to people who I think deal in the business, the kind of high stakes business, right? I mean, it isn't, and I'm certainly not trying to magnify its importance over other necessary things that happen, professions that happen in the world. Not at all. I'm not trying to be that way, but I sort of feel like, I want to connect with the healthcare team that cares for me. And so part of that, I connect with humor, and part of it, I connect with who they are outside. And so I kind of feel like that, I don't know, that's important to me.
Well, and I think for medicine, especially that, over the past few years where there's just been this huge down pressure on shortening visits, in the whole primary care world, and even with specialists too, they're spending such teeny little bit amount of time with their patients where it's harder to actually get to know each other, where in the past you had 45 minutes or an hour for a well-child check, and that is a thing of the past. And so using social media can be a great way to expand that relationship. And then if you have that good relationship, it fosters trust. So it improves the transmission of accurate health information between the patient and the provider, because that trust is there, and some of it is getting boosted by other sources, not just that in-person, face-to-face visit. So I think doctors with personalities is a good thing, but
Yeah.
maybe I'm wrong, especially as an emergency. I think the ED doctors, especially, because we're dealing with some intense stuff, and so we need to be able to laugh a little bit, not laugh at, but laugh.
Yeah.
Yeah. And I think that too, you have to also watch the line of this being disingenuine and making sure that that personality is yours too. I think it's very clear when people are trying to maybe, copy somebody else who has a large following, or, they're doing a certain style, and, you want to get the information across the same way, but, still being yourself is important in the videos too, or the tweets, or whatever they're using their platform for, because
People
I think
will know.
that's when you get into the line of like, okay, this person is like, what are their ulterior motives for doing this if they're not being their true authentic self?
Right. Yep. Yes. No. That's exactly right. Woo! Look at that one. Where it's after 10 p.m. So I'm putting up those comments now.
See, that's my Instagram late night hot takes. Sometimes after 11 o'clock, you never know. I might do something exciting.
Exactly right. But I think this is a really important. This is a really important thing. There's a time and a place for it. I do think the audience matters. I think that. You got to be careful with the snark factor. I will say that for professionals, healthcare and science professionals who have a presence on social media, I think that especially is so open. I would think as teachers too, that can be so open to context and to how that gets interpreted, that I think that's it is a fine line to walk too. And so that is what so that's what we think about that one. And
also being able to see that just because someone does have a large platform or a large following doesn't necessarily mean that the information they're providing is also true. So like just taking everything with a grain of salt, because we've shared, we know, but that's just, it's easy to, it's easy to see that somebody has done, maybe they have a great setup or everything is edited really well, and it's easy to think, oh, well, they must know what they're talking about. And I mean, I've definitely fallen guilty to it as well for a variety of different topics on social media. And then when you actually like delve into the information, you realize, okay, maybe some of the stuff is a little bit more exaggerated than it's supposed to be, and it's a little more theatrical.
Yeah, 100%. No, that's exactly right. So this is usually about into this live when Dr. Murray drops off for mysterious reasons, which we don't know why, and then she comes back in. So she'll be right back. I am very sure of it. Meantime, we talked about double masking. Do you really need to double mask? Do you really need to double mask? So that's the operational question, right? Do you need to? Does it help? Are we finding increasing data that wearing two masks protects you, protects others? Yes, it does. Here, she's back, as I said she would be. Hang on a second. Here she comes. Hi, friend. I said this is the time in the.
Right. I don't know what happens. I don't get a message. I don't get a. No, the computer just says, I'm done. We're done. We've done enough.
Right. So double masking, is it something that we think that is it a recommendation by the CDC for the general population? Yes. Should it apply to healthcare workers? Probably not, because of the N95 and the specific PPE that is directed for healthcare workers. So I think that's a different conversation, but I think there is increasing data that supports the double masking.
But I would prefer everybody to wear one correctly.
Yeah. Oh gosh. Okay.
Just wear one correctly, and maybe we'll.
The point of the double mask too, especially it's not two surgical masks. If you dig deep into the CDC recommendations, it's not. It's a cloth mask over top of a medical grade mask, and that cloth mask really just helps to try to help increase that fit and make a better seal. So that is that's one of the important points there.
And you will still get adequate amount of oxygen.
Right. Exactly right. Exactly right. Last, another question that I think we should just jump in. COVID affecting kids with mild to moderate asthma. Do you see more serious symptoms and hospitalization? So far, the data says no. Severe asthma, so children with very poorly controlled asthma. There has been, the numbers are small, period. So it's hard to make sweeping evidence-based conclusions based on this. The Quad AI, which is the American Academy of Allergy, Asthma, and Immunology, states that there is a theoretical concern for children with very severe, poorly controlled asthma. That is part of their position statement. However, what we are not—
they're at huge risk anyways.
Yeah, exactly. What we are not seeing is that for children with mild asthma, that they are at increased risk. We just aren't, which is fantastic. So that is important. How safe is it to go for an exam right now, being so close to face? Well, you know what? Plenty of folks came to see me today. So that is, I feel fairly confident that in the healthcare setting right now, and even in dentists and the orthodontists, that the PPE, the level of protective PPE and that's going on is adequate. What do you think, Dr. Marie?
Yeah, no, I agree. I mean, I think, again, the time you're protected, the time that you're actually super close to the person is very, very small. Physical exams really don't take 15 minutes. So it's pretty small, and everybody's masked, and yeah, I'm not worried.
And for an eye exam,
this might be.
Yeah. Go ahead, Rob.
Go ahead. I was just going to say this might be more of like a, regional question too, but like I know in certain areas, some of the facilities are also, people are tested regularly as well. So, just take that into account, some of the healthcare workers. I know that's not available everywhere, but, just know too that they're not going to be sending, hopefully, sick individuals to work. So you can hopefully have an extra, reassurance for that.
Yeah, 100%. Great point. If a 16-year-old can get a vaccine, should they?
Sure. I mean, is it? Yeah, the Pfizer they approved down to 16, right? So, if they have a comorbidity and they fit the criteria, then sure.
Yep. Exactly. Should they, with moderate asthma, should they be prioritized for the vaccine and wait until all kids are offered the vaccine? I'll give you this is my opinion now that I'm going to share. Kids 16 to 18 with moderate asthma so far have not been at increased risk. So I do not believe that they should be prioritized over older individuals, over teachers. I don't think that should be in the game. The data just doesn't support that they need that at this time. So that is that's what I think. So I would support that for the 16 and the 18-year-olds getting that. Any more info on type 1 diabetes connection to COVID? Any thoughts or any comments on that?
As far as, I missed the question. As far as you would
the link, the causation, link, association.
I don't know.
Nothing new on that.
Yeah.
I think what I will say about that is that as with many autoimmune diseases and many viral infections, once people have a viral infection, it tends to, for whatever reason, kind of open the gate for that autoimmune disease to manifest itself. So I am not surprised, would not be surprised to hear that there is an association between this virus and an increase in type 1 diabetes due to the fact that it's an autoimmune phenomenon. But there's no new hardcore science or genetic mapping or anything like that that helps us to pre-identify who is more at risk for that in the literature that I'm aware of.
Right. I haven't seen it. Oh.
Yeah. I haven't seen anything clear or, published that would lead to that. But just, so everyone's aware too, for the autoimmune, it would be, your body begins attacking one of the proteins in your own self that it shouldn't be. And then, you have a reaction to that instead of just having no reaction, which is normal.
Right. That's exactly well said. Yeah. So these are a lot of the emerging topics and the emerging questions that I think we are going to be answering over the next months and years as we study this more. And who's going to be there to try to curate all the information, sense of it for you?
All of us.
Group, right? We are.
Yeah.
Yeah, exactly right. So we're at 45 minutes. We went over a little bit like we tend to do. Should we start making these things 45 minutes rather than a half an hour?
I don't know. We'll see if my computer will participate. I don't know.
I know. Exactly right. I want everybody to know I've started in with the peeps already.
Oh boy.
So, yeah, it's time. It's time indeed. So look, we will be back next Thursday night to talk about the latest and whatever comes our way next week.
Hopefully the Johnson & Johnson info.
Yeah, hoping so too.
Right, yes.
Right. So just so everybody knows, you can, Dr. Elizabeth Murray is here on the Facebook at Dr. Elizabeth Murray. She is on Instagram at Doc E. Murray. Follow Rob on the Twitter. He's quite popular on the Twitter and on Instagram at Swandive Rob. And you have a YouTube channel that is Scientist Swanda?
It's just Rob Swanda. Yep, you can just find it under there. Or on Twitter, I have the link up all the time. So yeah, you can find all the videos, and they're being translated in other languages too. So if you have family members or friends who are across the sea, you can share the information with them as well. So that's really cool to see the education spreading.
Yes, right?
Very cool. Very cool.
We need to do that. We're going to fight the good fight and preach the good word. On that note, wishing everybody a fantastic week. We'll see all of you guys next Thursday night. And thanks for hanging with us tonight.
Be well. Take care.